Stars with the power to be seen across the world. We're not the future, we're the present. Invest in us and you will see the world is changing.
Because our bodies and the future we hold it. We want for you to see that everybody can win. Could it be education or contraception? Everyone will always be here to sing.
We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice. We on the ground in every area. We're the ones to make a world a better place. We want the best, we want the way. There is something for a future so bright.
Because our bodies, and the future we hold it. We want for you to see that everybody can win. Could it be education or contraception? Cause the boys we always be fine.
We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice.
We gon' climb up and then rise up. Won't keep our eyes shut, we ain't got enough. I know you tired of seeing things the same way, but in time you realize that things change. We the demographic dividend. You see the work that we putting in. I'ma stay true to me and use my opportunity to show you how to build a community with unity.
உன் வாழ்வு உந்தன் கையில், எதிர்காலம் உன் கண் முன்னில். மனதையும் உடலையும் பாதுகாப்பார். வேண்டும் வேண்டாம் என்று சொல்ல உனக்கு மட்டும் உரிமை உண்டு. தேவையில்லா குழப்பம் நீக்க வெவ்வேறு பல வழிகளும் உண்டு. உதவக்கரங்கள் உண்டு, முன் வந்து சொல்வாய் என்று. உதவக்கரங்கள் உண்டு, நீ முன் வந்து சொல்வாய் இன்று என்று. இன்றே முடிவு செய், உடல் நலத்தை உயர்த்தி வை. இன்றே முடிவு செய், உடல் நலத்தை நீயும் உயர்த்தி வை.
Because our bodies, and the future we hold. We want for you to see that everybody can win. Could it be education or contraception? Girls and boys will always be fine. We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice. We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice. We are family bright and morning stars with the power to be seen across the world. We're not the future, we're the present. Invest in us and you will see the world is changing.
Because our bodies and the future we hold it. We want for you to see that everybody can win. Could it be education or contraception? Everyone will always be here to sing.
We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice. We on the ground in every area. We're the ones to make a world a better place. We want the best, we want the way. Now there's something for a future so bright.
Because our bodies and the future we holding. We want for you to see that everybody can win. Could it be education or contraception? Cause the boys we always be fine.
We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice.
We gon' climb up and then rise up. Won't keep our eyes shut, we ain't got enough. I know you tired of seeing things the same way, but in time you realize that things change. We the demographic dividend. You see the work that we putting in. I'ma stay true to me and use my opportunity to show you how to build a community with unity.
உன் வாழ்வு உந்தன் கையில், எதிர்காலம் உன் கண் முன்னில். மனதையும் உடலையும் பாதுகாப்பாய். வேண்டும் வேண்டாம் என்று சொல்ல உனக்கு மட்டும் உரிமை உண்டு. தேவையில்லா குழப்பம் நீக்க வெவ்வேறு பல வழிகளும் உண்டு. உதவக்கரங்கள் உண்டு, முன் வந்து சொல்வாய் இன்று. உதவக்கரங்கள் உண்டு, நீ முன் வந்து சொல்வாய் இன்று. இன்றே முடிவு செய், உடல் நலத்தை உயர்த்தி வை. இன்றே முடிவு செய், உடல் நலத்தை நீயும் உயர்த்தி வை.
Because our bodies and the future we hold. We want for you to see that everybody can win. Could it be education or contraception? Girls and boys will always be fine. We are family and we are planning to go around the world telling everyone that we demand a voice. We are family and we are planning to go around the world telling everyone that we demand a choice. We are family and we are planning to go around the world telling everyone that we demand a voice. We are family.
good morning, afternoon, or evening to all of you joining from across the globe. With over 5,000 registrants from more than 150 countries, we have broken a new international conference on family planning record. I'm Dr. T, and I'm your host for the ICFP Not Without FP Forum. As many of you know, we were supposed to be in Pattaya City, Thailand today, celebrating the 2021 ICFP together, but this was postponed due to the COVID-19 pandemic. But I do hope to see you all in person in November in Thailand. This first ever ICFP Forum will serve as a strategic inflection point for our community worldwide to disseminate knowledge, celebrate successes, address the challenges, and identify the next steps necessary towards reaching our collective goals. While both the Not Without FP Forum and the in-person ICFP 2021 are centered around the theme of universal health coverage, the forum will focus specifically on the essential role of family planning in successful UHC schemes and the impact of COVID-19 on the sexual and reproductive health community globally. While we wait for the in-person ICFP, we wanted to provide an opportunity for the ICFP community to share the innovative ways this community has collaborated to ensure that family planning stays prioritized, even among service delivery disruptions, changing landscapes, and increasingly limited resources. Indeed, as you shall witness soon, our community has demonstrated leadership in how we continue to deliver in the face of historic challenges that COVID-19 has brought about. This year, we will also launch our new collective FP 2030 goals, raising the need for us to be even more imaginative to continue our momentum and showcase how innovation and collaboration will accelerate progress towards universal access to reproductive health and family planning services that save lives, improve economies, empower women and girls, and figuratively and literally transform our world. We hope that this event will inspire you to develop new, innovative research, partnerships, programs, and advocacy efforts that you will bring to share with us at the next ICFP. Throughout the forum, please share your voice and experiences via roundtable sessions, Q&A, live chats in breakout rooms, and with the Not Without FP and community contribution hashtags that can be found on each individual community session page. Distinguished guests, please welcome His Excellency, the Deputy Prime Minister and Minister of Public Health of the Kingdom of Thailand and co-host of the next ICFP, Mr. Anutin Charnvirakul.
Distinguished participants, it is my great pleasure to welcome all of you to this important event on the plenary session, USC Not Without FP. This entirely online convening will serve as a springboard toward the in-person ICFP, which will take place in Thailand. Ever since Thailand's population policy was announced in 1970, Thailand has achieved great success in family planning program through collaboration among governmental and non-governmental sectors, as well as international organizations. Due to the success in family planning program, together with the changes in people's way of life, more people in the new generation prefer to stay single. As a result, the population growth rate has decreased from 2.7% to 0.2% in 2020. Women at reproductive age have only 1.5 children on average, which is lower than the replacement level. Planning to adapt to demographic change is vital. Therefore, the Ministry of Public Health of Thailand, by the Department of Health, together with relevant agencies, has formulated the National Reproductive Health Development Policy and Strategy on the promotion of quality birth and growth. The policy aims to promote planned births through preconception, populations, and provision of child support. It also promotes safe motherhood through postpartum care and support high quality of life for the children. At present, family planning services are included in Thailand's Universal Health Coverage Scheme. However, there are still gaps in accessing these services among adolescents. We have found that the repeat pregnancy rate continues to be high. The World Health Organization recommends long-acting reversible contraceptives to prevent repeated pregnancy. In this regard, Thailand's National Health Security Office has been sponsoring long-acting reversible contraception services, including IUD and implant for Thai women aged under 20, as well as women aged 20 and above, who have gone through safe abortion. They can access the services at every service unit under the National Health Security Office network countrywide. Furthermore, Thailand has also emphasized the development of youth-friendly health services through the creation of supportive environment for adolescents to access reproductive health services. This is in line with the third goal of the Sustainable Development Goals, to ensure that women of reproductive age who have their need for family planning are satisfied with modern birth control methods. The success of the family planning in Thailand is not a result of medical personnel's efforts only. It is also due to the contribution from the village health volunteers across the country. They work at the community level to provide knowledge and understanding about appropriate contraceptive methods. The outbreak of COVID-19 highlights the vital roles of the village health volunteers in communicating and providing knowledge and understanding about COVID-19, which leads to the success of Thailand in controlling the spread of the disease. Moreover, the existence of the UHC, which ensures that everyone on Thai soil has access to comprehensive healthcare services, is another key success factor. Ladies and gentlemen, we are looking forward to strengthening collaboration with every one of you to create a world where the people have equality in accessing good family planning services through the UHC, and the well-being of people at all ages is ensured. That way, we are certain that no one is left behind. Thank you.
Thank you, Deputy Prime Minister. We are looking forward to joining you in Pattaya City for our next ICFP and learning about Thailand's incredible accomplishments in the areas of family planning, reproductive health, and in universal health coverage. Our next keynote speaker is Dr. Natalia Kanem, United Nations Under-Secretary General and Executive Director of the United Nations Population Fund. Welcome, Dr. Kanem.
Excellencies, distinguished guests, partners, and friends, we thank the Government of Thailand for co-hosting this dialogue together with the Gates Institute for Population and Reproductive Health at Johns Hopkins University. I also thank the organizing partners for your leadership and your steadfast commitment to family planning. Since the first International Conference on Family Planning in 2009, this has become our space for sharing knowledge, for addressing challenges, and celebrating success. This time around, we've adapted. Our virtual forum under pandemic circumstances brings the opportunity to connect with an even wider community to accelerate action towards our collective goals. It was Oscar Wilde who once said, "Everything in the world is about sex except sex. Sex is about power." And whether a woman or a girl has the power to decide about sexual relations will have a profound impact on her life. A woman is a farmer, for example, yet food insecurity is a key driver of sexual coercion and child marriage, power dynamics at work. We are here because we want every woman and girl to have the power to access family planning when it's right for her. And these are essential services for individuals, for nations, for this and the future generations. That is why UNFPA was quick to sound the alarm last year, predicting that with COVID, tens of millions of women around the world might lose access to contraception, with those who are impacted most, those already vulnerable. So I've been heartened by how strategic the family planning community is as we came together to contribute innovations, solutions for delivering more and more and better on the ground where it counts. COVID-19 has made one thing stark. Publicly funded healthcare must be available to everyone, everywhere, and reproductive health and rights, including family planning, are non-negotiable essentials as components of universal health coverage. The fate of women and girls is at the heart of individual and societal well-being. Providing decent access to contraceptive information and services at the scale required would reduce unintended pregnancies by 3/4 and maternal deaths by 1/4. Rights and choices. It comes down to the right of an individual to decide when or whether to have children. And it also brings women greater opportunities to become wage earners. As women gain income, they report better health outcomes. They achieve higher levels of education, and they are able to defend themselves and lower the incidence of intimate partner violence. These add-on effects are true for children in the household too. We want the promises of the landmark ICPD agenda kept, and we want family planning prioritized under universal health coverage and the SDGs umbrella. How much longer do we expect women and adolescents to wait? Our sector has proven time and again that meeting the unmet need for family planning is among the top line, cost-effective investments that the world can make as a best buy for development. Investments that create an ever-reinforcing cycle of empowerment for women and girls, for their families and their communities. Family planning, cost-saving, and economic benefits, in turn, allows countries to afford universal health coverage in the long run. A recent UNFPA analysis of 6 Latin American countries found that teenage mothers are far less able, 3 times less likely, to get a university degree. And they earn 24% less too. That income gap represents a tragic lost opportunity, a combined opportunity cost amounting to over $5 billion. Meanwhile, we see that family planning helps countries to harness a demographic dividend. That's the economic growth that results when, with family planning, birth rates slow and the working age population expands relative to the share of non-working dependent population. Many African countries with young populations, with 1/3 of the people falling between 10 and 24 years of age, have an opportunity now, if they invest in young people, if they make youth-friendly, comprehensive reproductive health care real, alongside adequate policies to foster human capital and reap that demographic dividend. Distinguished participants, the Sustainable Development Goals set an ambitious agenda for a safer, a fairer, a greener, and healthier world by the year 2030. Universal health coverage is a cornerstone of SDG 3, health and well-being for all. And in this era of coronavirus, we're seeing how fundamental health is to leaving no one behind. In 2019, at the Nairobi Summit on ICPD 25, a broad coalition stood up and made commitments. We committed to deliver on the promise of the ICPD Program of Action and the 2030 Agenda. And a key action, of course, is providing universal access to sexual and reproductive health and rights, including family planning, as an inseparable part of universal health coverage. What's urgently needed is a functional health system, one that provides all populations of reproductive age with access to voluntary family planning services and quality-assured modern contraceptives of the woman or adolescent's choice. It also requires a health system that prioritizes women and adolescents and protects them from financial hardship. No young person should have to choose between contraception and food. This is the unfortunate reality for too many young people who want to practice responsible sexuality, yet they face prohibitive out-of-pocket payments. Through this virtual forum, we have declared not without FP. How could universal health coverage be true to its name without universal access to family planning? Integrated into primary health care and featuring prominently in national development plans. Many countries are going to continue to require family planning support, especially in the context of the COVID pandemic. And I believe we can build back better by addressing family planning in humanitarian crises, sometimes compounded by the effects of climate change and inequality, investing in women and girls' bodily autonomy and their leadership. Now, funding can make the difference between life and death. Yet, the needs of women and girls continue to go underfunded, neglected. So as partners, we will need to act to translate the words into deeds, to devise the financing systems that ensure sustainable investments. Our sector, for years, has led the call for people-centered, human rights-based, and evidence-based approaches, and the use of data, real data, not fake ones, to identify and reach those who are in danger of falling furthest behind, including people with disabilities, older people, indigenous people, afrodescendientes, people of diverse sexual and gender orientation, and always women and girls caught up in humanitarian conflict, climate-related disasters. Global dialogues such as this one today help us to learn from each other's experiences, and they foster South-South cooperation. Last year, for example, Cambodia expanded its Health Equity Fund to entitle families to receive free health care, including family planning services. An additional 48,000 Cambodian households at the poverty line are now benefiting. In Madagascar, government renewed its family planning law to support community-based distribution, improving contraceptive security and increasing domestic resources for family planning through private sector engagement. At UNFPA, we continue to be laser-focused on 3 zeros that transform the lives of women and girls. 0 unmet need for family planning, 0 preventable maternal deaths, and 0 gender-based violence and harmful practices, all based upon high-quality data and evidence, and all making progress thanks to partnership with key actors like you, the international champions on family planning. This is a unique platform to accelerate support to make the universal availability of quality, accessible and affordable, and safe modern contraceptives real, once and for all. Dear friends, healthcare is something that is everyone's right, that every person on the planet deserves, not just a privileged few. We mustn't allow the COVID-19 crisis to become an excuse. Let us ensure that family planning is prioritized so that women and young people can reach their full potential. Let us come together to seek solutions and rise to the challenges before us so that everyone everywhere can access this human right. The author Tony K. Bambara once said, "The dream is real. The failure to realize it is the only unreality." The path to universal health coverage is one such reality. Let us say in unison, loud and clear, that the time is now, and then take action to make that dream a reality for all. Khab Khun Ka. Thank you.
Thank you, Dr. Kanem. I look forward to us all rising to this challenge to continue our essential collective mission. Next, we welcome Director of Family Planning at the Bill and Melinda Gates Foundation, Ann Stars, who will host our panel UHC Not Without FP, which will illustrate the importance of universal health coverage and demonstrate why integrating family planning is essential to the success of any UHC scheme.
Thank you, Dr. Traling, for introducing this panel, which I'm sure will be a fascinating and stellar discussion about the importance of universal health coverage and demonstrating why integrating family planning is essential to the success of UHC. The UN Political Declaration on Universal Health Coverage that was adopted by member states in September of 2019 laid out a vision for achieving health for all that aims at ensuring that all people and communities receive the quality health services they need without financial hardship. In adopting the declaration, governments agreed to ensure that by 2030, universal access to sexual and reproductive health care services, including for family planning, information, and education, and the integration of reproductive health into national strategies and programs, which is fundamental to the achievement of UHC. That declaration also calls for mainstreaming a gender perspective on a systems-wide basis when designing, implementing, and monitoring health policies, taking into account the specific needs of women and girls with a view to achieving gender equality and the empowerment of women. It acknowledged that the human rights of women include their right to have control over and decide freely and responsibly on all matters related to their sexuality, including sexual and reproductive health, free of coercion, discrimination, and violence. These are lofty goals. Our panelists today will address the nitty-gritty of what this means and how to achieve these aims. UHC requires addressing who benefits, what services are offered, and how to cover the costs of those services. Family planning presents specific challenges in each of these areas. Young people and women may not always be covered by UHC benefits packages. Family planning or contraceptive methods are not always defined as essential health interventions or commodities, or not all methods may be included, or they may be included, but not all costs are covered. Key family planning providers, including community health workers and drug shops or pharmacy owners, may not be defined as authorized providers in universal health coverage. Our panelists today will be addressing these issues and more. Let me start with our first panelist. James Kiarie heads the Contraception and Fertility Care Unit in the Department of Sexual and Reproductive Health and Research at the World Health Organization in Geneva. He oversees the unit's work on family planning, fertility care, and infertility. Prior to joining WHO, he was an associate professor in obstetrics and gynecology at the University of Nairobi, working on reproductive and maternal health, health worker training, and medical education. James has over 20 years of experience in teaching, clinical practice, and research in the field of reproductive health, focusing on HIV/AIDS, sexually transmitted infections, and family planning. James will share with us an overview of the global policy environment for family planning and UHC, introduce the UHC compendium that WHO just issued in December to guide countries in selecting priority health services for inclusion in their UHC packages, and will outline some of the challenges and opportunities related to integration of family planning into UHC. James, over to you.
Yeah, so thank you very much, Anne, for that kind introduction. And thank you to the organizers of this forum for inviting me to participate, to give a global perspective in terms of the policy environment for family planning in UHC. And the environment, the policy environment is quite strong in terms of how we look at family planning in UHC, starting from the 17 SDGs, which we know are either directly or indirectly related to health, and for which family planning is very important, the UHC declaration, but also importantly, we need to look back at the ICPD program of action, which I think for us in family planning and sexual reproductive health kind of sets our agenda clearly within the UHC context. I would like to highlight some of the actions that WHO has taken in terms of placing family planning centrally in UHC. The WHO 13th Global Program of Work has UHC as a strategic priority and for achieving the whole of SDG 3. And in fact, in terms of its organization, WHO now has two divisions that are dedicated to UHC, the UHC Life Course Division and the UHC Communicable and Non-Communicable Diseases Division. And family planning is in the UHC Life Course Division. This is very important that as an organization, we have readjusted and reorganized ourselves to be responsive to the universal health coverage and to be able to place all the aspects that are needed within this UHC framework. I will talk a little bit more on the UHC compendium. This is a repository for countries to access information on health interventions and to select priority health services. The version which I'm going to talk about today is version 1, which basically provides a list of health services and reference documents and data. But early in the second quarter of this year, we'll be releasing the version 2. This will introduce a selection interface and also provide some of the intersectoral interventions and also have data and resources on inputs and have linkages to the burden of disease and data on disease control priorities. Therefore, it will be a compendium that countries can actually use to select what interventions will be placed under the UHC and will address some of the challenges that Anne has highlighted that we face in family planning in terms of what is included in UHC benefit packages. I think the other thing I'll mention briefly in terms of what we have been doing in WHO is that we've really been looking more closely at ways to link and integrate family planning services with other services. I think in the UHC framework and thinking about universal health coverage, we will have to be more inclusive of what we provide within family planning and also think more about which other platforms family planning can be provided. So we've done a lot of work on contraception in MCH, in abortion services, in HIV and other disease management services, and also looking at providing HIV and STI and other communicable and non-communicable disease prevention, screening and management, or referral in FP services. I just want to give you a preview of the WHO UHC compendium. For those who are interested, you can find it at that link. And basically, it provides information on each intervention. So under the reproductive health and sexual health, there's a subgroup on sexual health and family planning. And then there's an intervention category of contraception and family planning, which covers all methods provides information on all the service delivery points and all providers. But for example, I've provided there for the male and female condoms and various tags that are placed under that. So I will not take time to go through, but I really wanted to introduce you to this UHC compendium because we would like you to have a look at it, and we hope that countries will be able to use it so that we make sure that no services, and particular for us, for family planning, are left behind. And then moving on, just to highlight some of the challenges for family planning in UHC. I think there are quite a number of challenges, but I just wanted to highlight these 6 challenges. The first thing is the balancing the needs and in terms of availability and affordability, in terms of coverage and the cost of delivery and financing. And this is where sometimes I think for us in family planning, we have to do a lot of work to convince the people who are making decisions on the importance and the role of family planning, that it must be included when they think of financing. I think one of the other challenges is the prominence of vertical programs, particularly for family planning, and which often are not integrated and are externally supported. So as we transition more to domestic financing, then this can become a challenge. There's rigidity in existing program management and structures, which is leading at times to tough wars. Because I think if you are to have universal health coverage, then it will be very important for people to look at health holistically. And of course, there are challenges of reducing resources. And even if we look at the way we do advocacy, I think we need to be more inclusive in terms of advocacy and move from very focused, issue-focused advocacy and to broader health advocacy that will be able to respond to the needs of a universal health kind of framework. And I think for the most, we know that people, it's difficult to change. Inertia always is one of our biggest challenges. I would like to highlight that although we have some challenges for inclusion of family planning in UHC, we do have some great opportunities. And one of the greatest opportunities, I believe, is the importance of equity and protecting vulnerable populations, the issue of gender equality and human rights. This has been our mantra in family planning from ICPD coming on to this time. And this is something that is now going to be very critical and central to universal health coverage. So this places at an advantage because we really do emphasize this in family planning programs. Looking at the policy environment and the political will, I think there is a will for a very inclusive UHC. For many countries, they really are intending to be as comprehensive as possible, and there is really strong support for inclusion of family planning. I think one of the other opportunities we can take advantage of is emerging technologies that break down silos. For example, dual prevention of HIV and STIs with contraception. I think self-care, technologies that enable self-care will place family planning more strongly in universal coverage, and also technologies that promote community-based distribution and inclusion of men in terms of contraception services. These new emerging technologies, I believe, will be able to highlight family planning within the UHC space. The other opportunity is that we will be seeing more and more evidence for horizontal scale-up. We have seen a lot of evidence from pilot projects, but I think we will need, and we are starting to see a lot of evidence from universal health coverage integrated services, not from pilot and demonstration project, but actually from scale-up processes in country. And I think documenting this process using implementation research approaches will be very key for us to place family planning centrally in universal health coverage. So I would like to end with a short presentation on how we can look at the COVID-19 impact to inform our thinking about family planning in UHC. And on this picture, I show the way and in different ways in which the COVID-19 pandemic has impacted family planning services, both directly in terms of family planning provision, in terms of affecting the way people are able to access the services, affecting the health workers, and even the supply chains which have been disrupted. But from our lessons learned, which I think as we think of UHC, we must really learn lessons from the impact of COVID-19 and be able to place family planning more strongly in UHC. I think one thing that has emerged is that family planning must be promoted and seen as an essential service. I think we cannot take this for granted, that everybody views family planning as an essential service, and we must do work to ensure that it's recognized and as such. And also the importance of family planning as part of health interventions. In some places, you find that family planning is even sometimes placed outside the health ministry, but it is important that we see this as a core health intervention that must be delivered with other health interventions, particularly when resources are limited. And the other part, I think the lesson of integration, as I've highlighted, is very important for us to start moving to more integrated services, both provision of family planning in various platforms and also providing different services in family planning services. And most importantly, I think demand, that the importance of demand. We've seen that in countries where there's demand for services, then there's less impact. But when there's low demand for family planning, so I think continuing to promote demand for family planning is some work that we need to continue doing. And this will be very important for us to place family planning within UHC and for us to avoid some of the kind of disruption that we have seen with the COVID-19 pandemic. So I would like just to close by thanking you very much and just to highlight that you can follow us, our department, on Twitter, and also you can visit our website, which I've given there, and there you can be able to find the various resources that I've already mentioned that are available from WHO. Thank you very much, and over back to you, Anne.
Thank you very much, James, for that excellent presentation and introducing, I think, and setting that context for the benefits as well as some of the challenges of including and integrating family planning into UHC, including in the context of COVID-19, this pandemic that is still affecting so many of our countries and so many of our health systems. Our next panelist is Dr. Natasha Kaoma, who is a global reproductive health champion, a medical doctor, and an epidemiologist. She is the CEO of Copper Rose Zambia, a youth-led organization that works with adolescents and women by providing sexual and reproductive health and rights awareness, menstrual health management, youth leadership, and economic empowerment programs. Natasha is a Family Planning 2020 reference group, youth focal point, and a member of the Lancet Commission on Adolescent Health and Wellbeing. She's a graduate of the University of Zambia with a focus on human biology, medicine, and surgery. Natasha will discuss the National Health Insurance Authority in Zambia, which was launched in 2019, and its inclusion of family planning and other reproductive health interventions in the minimum benefits package. She will highlight in particular the role of civil society and youth advocacy in shaping the implementation of the national UHC plan in Zambia. Natasha, over to you.
Thank you so much for having me, and thank you to everyone that has made it possible for us to be here today and for me to speak. I would like to pass my sincere gratitude to the Gates Foundation and many of the partners that have made this possible. So when we talk about universal health coverage, we might want to ask ourselves, what does this really mean? A lot of times we have heard this word around in conferences, in meetings, but we took our time to ask around what young people mean and what they understand by universal health coverage, and just allow for a short video for us to see what they had to say.
Universal health coverage. I am not very much familiar with it. Well,
it sounds to me like you're talking about how we should cover, make people aware about health issues, throughout the world.
it means my internal health as a human being. Yeah. And universal, it's a worldwide thing, right?
Where people come in to access their primary needs freely, things like condoms, contraceptives, and the other things.
Being able to plan how many children you want to have, if at all you want to have any. It also means being able to decide whether you're ready to have a child or not. Like for example, myself, I'm still in school, so I'm not yet ready. I can decide to abstain, or I can decide to use certain family planning methods, which in my case, I can't call family planning. I can call them contraceptives because I'm not even trying to plan a family. Part of your income or part of the money you generate, maybe like a 1%, goes to your health insurance so that your health is covered for. And you can just walk to any healthcare facility and your information will be in a card. Like there's a care card, what they're calling a care card that has been introduced in Zambia, and all your information will be there and you'll be able to access all the help you want. Thank you.
So from that video, it is very clear that there is very little information about universal health coverage for the average person working on the streets. I'll draw you to the universal health coverage situation in Zambia. So Zambia is a country that is in the southern eastern part of Africa with a population of about 18 million people. For the last couple of decades, Zambia has been providing healthcare services at primary healthcare level for free. That means that anyone can walk into a health facility and they don't need to incur any costs associated with going to a health facility. But from sometime around 2014, there have been talks about a national health insurance scheme and universal health coverage being part of the national health strategy. And so in 2018, after various consultations with the civil society and with many different stakeholders, the National Health Insurance Act was formulated. From that time, in 2019, the National Health Insurance Authority was launched as a way of implementing the Act of 2018. And when we think about universal health coverage in relation to the national health insurance policies that are in place, family planning is one of the priorities, and it is included in the minimum benefits package. This is not something that is happening in many countries, and Zambia is one of the countries that is leading the region in showing that reproductive health is a priority. And so family planning commodities are included, which covers short-term methods, long-term methods, including permanent methods, and all commodities are covered in this package. Now, you may be asking yourself, what are some of the key challenges that are coming with universal health coverage and reproductive health in general? One of the biggest challenges that we faced in Zambia are the socioeconomic demographics. When I think about socioeconomic demographics, I'll let you in on a few statistics. So the country has about 18 million people, and those that are in formal salaried employment are somewhere between 3 to 4 million people. So what that means is that a huge part of the population is expected to be carried by the small number of people that can and are able to subscribe to this insurance. So the socioeconomic demographics prove to be a challenge because some people are earning money but are in the informal sector, and it is so much harder to capture those people to be included in the national health insurance and in other universal health coverage efforts. A second challenge that we have observed as far as family planning is concerned, and I can see that my fellow speakers alluded to this earlier, is the cultural and religious beliefs on reproductive health. There are many organizations that are working to educate healthcare providers, but one thing that I've seen in my work so far is that even if we train healthcare providers for a short amount of time, they are coming from this society that still has cultural and religious beliefs that feel that women shouldn't have sex if they're not married, or women should wait and use natural methods instead. And there's so many myths and taboos around family planning. And so in order for us to see success, we should be working towards a more holistic way of doing things, which enables the entire population to see family planning in a different way and not just targeting healthcare providers. Also, there has been insufficient funding for family planning compared to other sectors. Most of the funding that is going towards family planning is for advocacy and not exactly for service provision, whereas other health indicators like HIV do have funds which literally procure drugs for those that are living with HIV. So when you look at it from two sides, family planning is considered to be a government responsibility, whereas other health sectors, for example, other sections of health like malaria, tuberculosis, and HIV have significantly higher amount of funding. This has also been seen in the COVID pandemic, because with the COVID pandemic, most of the healthcare visits were reduced. And so those that were receiving antiretroviral treatment were given treatment 6 months in advance, whereas family planning could only go as far as 2 months in advance. And this also brings me to some of the inequalities. There are lots of inequalities outside the health sector that may have healthcare implications. I'll give you an example. Even if healthcare is free and people can access it, if people are living in rural areas, for example, in Zambia, 52% of the population lives in a rural area. And what that means is that sometimes they are further away from healthcare facilities. So even if the healthcare facility is offering the service for free, they still have to face challenges in accessing the service from distance to healthcare facilities and many other inequalities that may be outside the health sector, but do have health implications. And lastly, COVID has brought up a huge challenge in the sense that the COVID pandemic has the potential to undo the little gains that have been made as far as family planning and other sexual and reproductive health services is concerned. So I work with an organization known as Rose, and we are a youth-led organization. And one of the things that we have been doing in order to contribute to improving outcomes as far as reproductive health is concerned is advocacy for family planning and youth-friendly service provision. And we are doing this by, one, participating in decision-making spaces. We are participating in revision of documents and ensuring that young people's needs are demonstrated or young people's needs are expressed in these high-level spaces. We are also working on collecting data and evidence to ensure that we're not speaking from without, but we're speaking from using the data that we have in order to influence policy and influence change at district level. We're also coordinating the youth movement for action, because for a long time we have known that young people are some of the most dynamic people that could bring about change in our society. So we are coordinating young people through youth action movements, as well as through community action teams, to ensure that they are playing a role and they are participating in decision making at the smallest micro level of the healthcare system. Additionally, when it comes to things like reproductive health, I think it's not fair to only point out what is going wrong or point out what is going right, but it is also good for us to supplement government efforts. And what we are doing is we are supplementing government efforts through service delivery programs, as well as social and behavioral change communication. It has been mentioned that one of the biggest barriers is social and cultural beliefs. So we are playing our part through holding smaller level discussions, meeting with traditional leaders and chiefs to ensure that they understand what their needs are and how they can play a role in making these things so much easier for the people whom they represent. And this is not in everything we're doing, but this is an idea of some of the initiatives we have put in place to get us towards the universal health coverage goals and family planning. So when it comes to universal health coverage and family planning, there are some opportunities that are available at this moment, which we could take hold of, and we could see some gains as far as universal health coverage and family planning is concerned. One of them in the Zambian context is political will. There is a lot of political will and political involvement in ensuring that universal health coverage is made a priority. The Ministry of Health has made it one of its high priorities, and this has been reflected in many of the policies and documents that we're using as a country. Even for documents like the adolescent health strategy and many other strategies, there is a lot of work that is going into making sure that universal health coverage is made a reality. There is a health financing strategy, which is supposed to run from 2017 to 2022. And this gives a detailed guide of how we as a country could get to our universal health coverage targets. And this includes family planning, which just shows that there is a lot of willpower in ensuring that this happens. Another opportunity is a robust civil society movement. The civil society movement in Zambia is very much aware and very much energetic, and we are willing to do everything we can to ensure that universal health coverage does factor in family planning. And this was seen in the health financing strategy and many other, the implementation of the Act, of those processes. And we are hoping to see that these things are, for example, when it comes to having things in the documents, is very different from ensuring that commodities are available in facilities. And that's where the advocacy comes in to ensure that there is accountability at the lowest level. And lastly, some of the key opportunities have been in the existing primary healthcare infrastructure. Free primary healthcare has been the norm for the last couple of years. And so we are seeing that as an opportunity, and it is a baseline for us to start and ensure that some of these services are going all the way up to tertiary systems. Thank you so much. And I'll pause here for now.
Thank you very much, Natasha, for that excellent presentation. It's really helpful to see some of the challenges as well as some of the key opportunities. And I think you're highlighting the role of civil society and activism in shaping the UHC programs and strategies in the Zambian context is really helpful. And I look forward to hearing more when we get to the Q&A. Our next panelist is Frewat Nigatu Yimer, who is the Acting Executive Director of the International Institute for Primary Healthcare in Ethiopia. The institute, which is affiliated with the Ethiopian Ministry of Health, provides technical assistance in building strong primary healthcare systems, focusing on capacity building, training, program design, and implementation. Before joining the International Institute for Primary Healthcare, Frewat worked with Project Hope as a community service director for a USAID-funded HIV program. She has a degree in medicine from Vimy University. Frewat will share with us an overview of the Health Extension Program in Ethiopia, a comprehensive community-based platform that aims to provide primary healthcare through a network of health extension workers throughout the country. She'll also focus on IIPHC's efforts to strengthen and support that health extension program. Frewat, over to you.
Thank you, Anne, for the introduction. So as stated, I will be presenting in a very short time about the International Institute for Primary Health Care, as well as the overview about the Ethiopian Health Extension program, especially related to the path to universal health coverage. So as mentioned earlier, the International Institute for Primary Health Care in Ethiopia was established by the Ministry of Health in 2016 with the objective of strengthening Ethiopia's primary healthcare system to meet the Sustainable Development Goals for health and as well as the universal health coverage. It was also built on the objective of building capacity through training and also serve as a global hub for PHC related information. This is a hub where we gather different information regarding primary health care and community health programs and target that to global audience. So you can go to our website and see this information on www.iifphc.org. We also carry out different health system related implementation research, as mentioned earlier, primarily focusing on primary health care and community programs, community engagement. And the other primary objective was to contribute to global advocacy for universal health coverage, especially using primary health care as a vehicle. We have 5 core competencies. We provide capacity building through trainings and technical assistance. We have knowledge generation and management core competency. We also have a competency of disseminating evidences and best practices. We also do advocacy and partnership formation, especially advancing the agenda for primary healthcare agenda and contribute to monitoring and evaluation related to primary healthcare systems. So we have a 5-year strategic plan that runs from 2020 to 2024. And within this strategic framework, or within this strategic plan, we have a vision of becoming a global center of excellence for primary healthcare, and also a mission of proactively engaging and driving the advancement of primary healthcare policy design and program for the attainment of universal health coverage. So when we see Ethiopia's experience related to primary health care and universal health coverage, a focus on primary health care and engagement was initiated in the early days of the millennium, around 2000. And the reason for that was there was a limited health infrastructure. We had uneven distribution of healthcare workers, and the number was also limited on top of that. And there were concurrent problems, health-related problems in country, like maternal and child health problems, infectious diseases, and environmental health problems. So this all led to the birth of the health extension program, with a very significant political commitment from the government. And the health extension program is a community-based healthcare delivery system that makes essential health services available through community participation and engagement. So the health extension program is the smallest institutional framework for achieving universal health coverage in Ethiopia. And it does that by increasing access to utilization of different promotive, preventive, and curative essential health services. It produces model families and communities that achieve different health service packages related to the health extension program, and at the same time reduces opportunity cost related to health. It also enhances community engagement and participation in health, which is the pillar in the health sector strategic plan in Ethiopia. It's also the backbone of the health policy. So it tries to enhance that pillar. The health extension program currently has 18 packages of services. And previously it had 16 packages at the beginning, and those packages grew in time, and currently there are 18 packages. And these packages are categorized in 4 thematic areas. The first one is family health service, where we have family planning as part of this thematic area. And the family planning services are provided by the health extension program in different approach, starting from health education, and with counseling, and also provision of some clinical services, including implant on insertion. So over the last 20 years, the health extension workers number has increased from around 3,000 to more than 40,000 currently. So you can see how the country is trying to address equity service access by increasing the number of health extension workers who serve a catchment population within their vicinity. So this is also a big achievement and a significant capacity building with training this health extension workers, including refresher trainings, has happened in the past. So as a program that stayed 20 years, we had a lot of challenges, and there were some studies that were done in specific geographic areas, focusing on different services or a single service at a time. So in 2019, the country and the Ministry of Health, in collaboration with stakeholders, decided to do a national level assessment of the program by an external evaluator. And this national undertaking revealed different challenges and opportunities. And we can summarize in a nutshell the challenge and opportunities in 2. The first one is, it might be a challenge, but it's also an opportunity for future advancement and revision. There's a wider expectation from the community when it comes to health extension programs. So they want more service, they want more coverage, they want more packages of services to be delivered. The other challenge was there was a suboptimal coverage, especially in specific geographic areas. There is also quality of service related challenge because of infrastructure issues, commodity issues, human resource, information system, leadership and governance at all levels, and also community engagement challenges. So those challenges and opportunities created a reason for development of a 15 years roadmap, where the country is now working on optimization of the health extension program. The rationale for this optimization is first of all to provide a structured guidance for the overall program and 15 years down the line. And the second one is to address socioeconomic challenge. So there are changes in country that we're seeing. We are seeing a lot of urbanization, where the initial intent of the health extension program was to address most of the rural population where access of service was a challenge. And also responding to different epidemiologic shifts is critical because we're seeing change in our epidemiology. And as I have mentioned earlier, meeting the community expectation, there is an increasing an increase in demand and increased community expectation from the program. And the country also revised its essential health service package in 2019, which also included additional essential health service package to be provided by the health extension program. Also, improving the performance and sustaining the health performance is critical. And the service model should also be adjusted, especially, as I have said, because of different epidemiologic, socio-economic, and community level expectations. So adjusting those service delivery models was the other rationale. So within that optimization of the health extension program, the roadmap has 6 strategic areas for the next 15 years that are expected to address most of the challenges, and they also primarily build on the opportunities that were witnessed. The first one is ensuring equitable access to services, especially access to essential health services, and at the same time also addressing equitable utilization of those services. The next one is improving the quality of service that is provided by the health extension program. And the other one is ensuring a sustainable financing mechanism for the health extension program. As I have mentioned, it's a significant investment to train, retrain, and retain health extension workers in this program for the next 15 years. So ensuring sustainable financing is one important element, and eliminating financial hardship that's faced by provision of health services, the other one. The next one is strengthening community engagement and empowerment. We had different approaches when it was related to community engagement in the past, but the finding from the assessment revealed some challenges, and those challenges need to be addressed in the coming few years. The next one is what we have learned from COVID-19, which is ensuring resilience and being able to have a health system that can stretch in case of public health emergencies, and at the same time be able to accommodate essential health service provision. So that's one of the strategic area. And the last strategic area is cross-cutting and is very critical in the implementation of the health extension program, which is strengthened and continued political leadership. The basis for the establishment of the health extension program was the political leadership from the government, and that needs to continue 15 years down the line. And the need to have a multi-sectorial engagement. We've learned that health-related problems are not only health-related, and they cannot be addressed with only the health sector responding. So we need different sectors collaborating and engaging to address those health-related problems. Thank you very much.
Thanks very much, Freywat, for that excellent overview of the very innovative and comprehensive primary healthcare program in Ethiopia, including the health extension platform, and for the transparency around both some of the challenges as well as the very impressive achievements of that program. So let me turn now to our last panelist and last presentation. Dr. Indu Bhushan serves as the CEO of Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, known as PMJ, and the National Health Authority of the Government of India. This is the largest health coverage scheme in the world, serving roughly 540 million people, which is larger than the coverage of the United States, Canada, and Mexico combined. Indu holds a doctorate in health economics and a master of health sciences from Johns Hopkins University, and is an alumnus of the Indian Institute of Technology, Banaras Hindu University. His 37-year career spans multiple sectors and organizations, including the Indian Administrative Service, the World Bank Group, and the Asian Development Bank. Indu will describe PMJ, including its innovative approach to ensuring equity and access and coverage, with no restrictions based on family size, age, and gender, as well as a number of innovative and far-reaching aspects of the program. Indu, over to you.
Thank you, Anne, and thank you for inviting me to this conference. In my short presentation, I'll share with you about my scheme, how it is helping more than 500 million Indians, and how it's supporting the cause of family planning. If you look at the disease pattern in India, there is a marked epidemiological transition. We are seeing that incidence of communicable diseases is coming down drastically. At the same time, prevalence of non-communicable diseases is increasing in a big way. At the same time, we are seeing that incidence of injuries, road accidents, and other injuries is also increasing. Therefore, India is facing a triple burden of disease. We are lucky to have also a big decline in total fertility rates. We have 36 states and union territories, and about half of them actually have reached replacement level fertility. Overall, India is close to about 2.3 or 2.4 in terms of total fertility rate. But if we disaggregate this with the population in socioeconomic status, we find that the poor population tend to have larger number of children, and they are in the need of providing provision of more information and greater services for family planning. At the same time, what we find is that the out-of-pocket expenditure is very high for all different kind of services, including family planning and tertiary level services. And this expenditure pushes more than 60 million people every year below the poverty line. And of course, this is not acceptable. And to assure that all Indians have access to quality health services, including family planning services, our Prime Minister, Mr. Modi, launched a scheme called Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. Ayushman Bharat means Long Live India, and this scheme was implemented to make sure that no one should be denied services only because they can't pay for it, and no one should go into poverty because of expenditure on health or family planning services. The basic contours of this scheme are as follows. It covers close to about 540 million people. This is a population which is bigger than US, Canada, and Mexico all together. And we are covering about close to 100 million families. And the coverage includes 500,000 rupees, which is close to about $7,000 per family per year for all serious illnesses which require hospitalization. And one key feature of the scheme is portability. Benefits can be taken to any part of the country. They don't need to be stuck to their state or district. They can go anywhere to any impaneled hospital all over the country. And there's no cap on family size, age, gender, and it covers all pre-existing conditions. So with that, the question is that what is new? What are you providing in this country which was not provided earlier? It is revolutionary in many senses. One, that it provides option to the people. So we are giving this option and this authority and this big like money in the hand of beneficiary or the poor person, that they can choose. They have a choice. They can go to public or private. Earlier, in general, large part of public services were used by the poor. They could never afford private services. Whereas Private sector is providing about 70% of the services in the country, but these services were largely not accessible to the poor. Now, with this scheme, they can go to public or private. Within private, they can go to X or Y or Z. So they now have a choice. They have the option, and they can choose any hospital. So they will be going and they'll be voting with their feet, and they'll go to those places where they perceive they are getting the best quality services. So that's one. And of course, uh, quality family planning services are available in both public and private. They were earlier priced out of private services. Now they have access to private services. One thing that we have seen is that when families have to pay for health services, including family planning services, they tend to prioritize more powerful within the family. So women, children, they are not prioritized. And when they don't have to pay, obviously everyone gets services. And that is actually extremely critical for family planning services and reproductive health services, where more often than not, women are our target group. And once it's a demand side scheme where we are providing or we are paying for those services, then the intra-household inequalities are also addressed. And incentive within families to ensure that those services are available and provided to women and children also gets done. Second thing that this scheme has brought in is that it has created an incentive for public sector hospitals, because earlier public sector hospitals were just agnostic who's coming, and the provision of services were available to everyone. And in most cases, people who were better placed or had better connections would get prioritized. But now in public hospitals, if they provide services to poor people, our people, they'll get paid. And the providers in public hospitals will also get paid more if they are providing service to our beneficiaries. Therefore, there is an incentive in public hospitals to prioritize the poor. So for them, the person is VIP because if they provide service to the poor, they get paid. If they're providing services to the non-poor, they'll not be paid, because they usually the public sector services are free, so they'll use free services. So here we are providing incentive to public sector hospitals to be better, like provide better services to the poor. Third is that our earlier schemes were focusing largely on public sector hospitals. Here, we are utilizing the capacity of both public and private together. And so we are expanding the pool, and which of course helps the poor. It helps them get services both for serious illnesses, but also family planning services. Fourth issue is about the quality. How do you ensure that they are getting, poor people are getting services, but also quality services? Here, because since we are paying for services, then we can also define what kind of services should be there. Therefore, all our packages, or most of our packages, we have developed what we call standard treatment protocols. And we have developed the list of things that should be provided, a list of the process, the kind of medicines, kind of follow-up that should be done. And we will make the payment only if those protocols are followed. So we can ensure that the quality services, because we'll be making payment only after we are convinced that services were quality services. Finally, this scheme is unique in the sense that we have developed end-to-end digital platform, which makes this scheme cashless and paperless, which reduces a lot of inefficiencies, it improves responsiveness, it helps in us in terms of closely monitoring the scheme, and it also helps beneficiary and people in terms of getting better services. So in many ways, this scheme has brought in many new concepts in terms of provision of services, which has made it more responsive and efficient. So the scheme PM Jai has brought in revolution in India in terms of providing services to the poor, health services to poor, ensuring quality health services to poor, and ensuring that they don't become poor because of expenditure on health, and they are not prevented from using services because they can't afford it. I would like to end with a quote which is very close to our heart, and which this scheme is trying to address, is that when this comes from Dr. Martin Luther King Jr., that of all the forms of inequality, injustice in health is the most shocking and inhumane, and this scheme tries to address that sentiment. Thank you very much again for inviting me.
Excellent. Thank you very much, Indu. There's a lot of substance in your presentation, and I'm sure it'll be great to look back and probe some of those specific characteristics and some of those innovative and promising approaches that you've highlighted. So let's turn to our question and answer portion of this panel. And let me start by going back to James. James, I'd like to actually pull up this discussion a little bit and help us think through from the perspective of if we're looking at policymakers, at decision makers, and those who are allocating resources and making decisions about the content of UHC, what do you see as the key arguments for why we need to prioritize the inclusion of family planning in UHC benefits packages? What are the arguments that you've seen that are effective in convincing policymakers to do this?
Yeah, thank you very much, Anne, for that question. And I think the issue of family planning in UHC is very critical. One of the key arguments for why we must really have family planning, because UHC is really about resources, and as we've heard from the presentation, particularly from Indy, about the way they have been able to bring resources to bear. If you think about efficiencies and what is most cost-effective, we know that family planning is among the most cost-effective interventions that you can provide. So it would really be a huge injustice to exclude or to limit family planning in really thinking about universal health coverage. And I think the issue of cost-effectiveness is a very important argument for family planning. And I think also if you think about family planning, it's really key when communities are able to choose when and how many children to have, they are able then to achieve all the other SDGs. I think almost all the SDGs will not be achievable if this basic right of women and couples is not available to be able to plan their reproductive health and to be able to access family planning services. So this is very important for policymakers to be aware of. And I think also to where Indu has ended, that the issue of rights, that it's actually the right of women, the right of adolescents, the right of couples to be able to plan their families. And it is an issue of justice for them to be able to access these services as part of universal health coverage.
So thank you, James, for that overview. So Natasha, thanks again for your presentation. Could you talk to us about the specific role of civil society advocacy in shaping the national health insurance plan in Zambia? both in shaping the design of the plan, but also the implementation and monitoring of the plan?
Thank you so much for that question. So when you look at shaping of the UHC agenda or the national insurance agenda, the most important thing for countries that have not put out a benefits package, that's usually the best place to start. You have to attack before anyone does anything, because it's so much easier to advocate for something to be included into the package as opposed to package is already set. Sometimes maybe the review is only happening after 2 years or after a set amount of time. So what was done in Zambia is that there have been many organizations that were working on ensuring that the benefits package includes family planning. It was not very difficult because from Zambian context, there were already services being provided for free. So it was just on in making sure that healthcare and reproductive health services are included into that package. So that is really the role. But after that is done, most of the work goes into ensuring that these commitments are met. One of the ways that we're doing this is commodity tracking. Many civil society organizations have scorecards or different tools that are being used to track availability of commodities, because it is one thing to say that something can be obtained from the facility, but if the facility doesn't have it, it's as good as saying that they're not allowed to get it. And that really is where the bulk of the work is. So accountability mechanisms, using things like scorecards and toolkits and many different areas. But also one last role is increasing awareness, because for a long time, young people and even just people in general of reproductive age have so it's very important to get people to go to the facilities. Lastly, something that insurance has brought as a challenge, which I maybe forgot to mention in my presentation, is that when you're on someone else's plan, then the risk of confidentiality issues, because what happens is if someone gets a certain kind of drug and they are covered on another person's plan or someone else is paying for it, then they'll see what they're using. This may not be a problem for couples with a maybe husband or wife situation, but it becomes a problem, for example, a young person that is covered on their parents' plan. The moment they get pills or condoms, it's registered onto that platform, and that's where the issues are with confidentiality. And this is something we're trying to work around, because it's a very complicated thing to go around, but that's usually where the challenges come.
Great, thank you for those additional points and insights, Natasha. So Frewa, turning to you, how is COVID-19 affecting the health extension program, and in particular, affecting the provision of family planning services?
Thank you, Anne. That's a very important and timely question. So the COVID-19 response and the pandemic has significantly affected the health extension program. As I mentioned earlier, we realized that during the revision of the development of the roadmap, which actually made us to rethink about devising strategies and initiatives towards a resilient health system and a resilient primary healthcare system. So the health extension program was also engaged to be part of the COVID-19 response, especially related to prevention and health education for the community. They also did screening, so which was demanding, requiring house-to-house visits, and maybe diverting their attention from the routine packages that they've been providing. That's one thing. The other thing is related with the family planning services. The COVID-19 has created a significant burden on health facilities, and these health facilities are also expected to respond to the pandemic related to screening, being a treatment center and the like. And there was a misconception at the beginning by the community that you don't need to visit health facilities because that's where the COVID-19 pandemic is happening. And those kinds of misconceptions need to be addressed, and the healthcare providers at the same time need to understand that they should be able to provide essential health services while doing, while conducting the public health emergency management. So to address that, a third strategy was developed, and maternal and child health programs were also prioritized, and they developed a guideline where health extension workers and other healthcare workers will be guided strategically on how to provide those services during such a pandemic.
Thanks very much, Freywat. Indu, I'd love to turn to you. Thank you again for sharing that overview of PMJ and of its many innovative and far-reaching elements. You mentioned a little bit at the end about the cashless and paperless aspects of the system. Could you talk to us a little bit more about that? How has that affected both efficiency and the quality of the care that is provided?
Thank you, Anne. I think that's a great question. And I would just like you to imagine trying to find a person from a list of 500 million people and confirming that person is indeed eligible for our scheme. And then ensuring that one of the 24,000 hospitals which is providing services gets payment on time. And just imagine if in a day we are providing treatment to about 25,000 people, making a follow-up with those people and ensuring that they indeed got quality services. All this is not feasible unless we have a strong IT platform. As I mentioned, that we have this end-to-end IT platform, which ensures in terms of that we can identify a person, that the person is eligible. We can authenticate this person's identity using, we have a unique Aadhaar ID, using the biometric that this person is not impersonating someone else. So the person, if the person says he's Indu Bhushan, he indeed is Indu Bhushan. The IT system also helps in terms of pre-authorizing the treatment once all the papers are submitted. And after pre-authorizing the treatment, this system also tracks the whole treatment while the person, what kind of treatment was given, what kind of implant was provided, and what kind of follow-up care was prescribed. Then after that, this same platform is used for making payment to the hospital in a paperless manner through the IT network. And this again, moving forward, this same platform is used to seek feedback from our beneficiary about the quality of services, or if the person was charged any money. Therefore, all this couldn't have been possible without IT platform.
All right, I think that wraps it up for us today. Thanks again for our excellent panelists, for James from WHO, Freywat from Ethiopia, Natasha from Zambia, and Indu from India for sharing the global and then the very specific and very concrete country perspectives on progress and challenges with rolling out UHC benefits packages and strategies, and in particular with the inclusion of family planning. I think we've had some really helpful insights, evidence, and experiences around a range of factors around the importance of getting the policy and the benefits package right from the beginning, but also about the importance of how those packages are rolled out in engaging civil society and being demand-driven and being responsive to the needs of individuals, families, and communities in how these strategies are implemented. And I think we've also had some really solid evidence and insights around how and why family planning needs to be a core element of UHC packages around the world, as the global community strives to implement and achieve that UN declaration on UHC that was adopted in September of 2019. Onward on our journey to 2030 and to achievement of UHC and to the achievement of the Sustainable Development Goals. Thanks again to our panelists, and thanks to our sponsors and organizers. Take care.
Thanks to you all for that incredible panel and for kicking off this two-day event. We are looking forward to diving into the scientific panels next, featuring 3 concurrent sessions that represent the categories of abstract presentation at ICFP: research, policy and advocacy, and program implementation. We'll hear about some examples of how organizations across the family planning community are promoting innovative solutions and adapting to the new normal to ensure progress made on family planning is not lost. As well, the community sessions will highlight how faith actors are successfully reaching their communities with family planning messages, how programs are being implemented in humanitarian settings, and the scientific subcommittee will share best practices for writing a high-quality abstract. When you have a moment, please be sure to visit our co-hosts, sponsors, and partners in our virtual exhibit hall, without whom this forum would not be possible, and connect with them at various forum side events listed here. Also, be sure to share your voice with the hashtag NotWithoutFP and follow us and today's conversations on Twitter. And join me again 3 hours from now for Real Talk, Real Stories, Real FP, where our community members from different countries will share firsthand personal stories on why family planning, access and care is essential to them and how it's been affected by the pandemic.
Wow.